it is my pleasure to chair this roundtable. We start with questions to two of the panelists that I will introduce now, and then I will introduce the other when they present. Our first set of panelists is Ms. Elisabetta Zanon, who is the Chief Executive Officer of the European Cancer Organization in Belgium. She has been previously Chief Executive, a professional with more than 20 years of experience in European affairs. And our other panelist to start is Professor Xavier Matias-Guiu. Xavier is the current president of the European Society of Pathology, and he is based in the University Hospital Arnau de Vilanova in the University of Lleida, Spain. So thank you. And I would like to ask my first question to Elisabetta, saying, what will be the implications of the current workforce shortages in the future?
Thank you very much, Marta, and good afternoon, everyone. Thank you very much for the invitation to join this panel. First, let me say that the workforce crisis in Europe is really a very serious problem. I'd like to share a few numbers just to illustrate this. There is an estimation that in the European Union alone, we are currently having a shortage of 1.2 million healthcare professionals. There are also additional, let's say, searches data showing even a bigger problem at European level, for example, with data from WHO projecting that by 2030 we will have a shortage of more than 4 million health workers in Europe. And this is clearly a sign that there is an emergency. We are in a situation of crisis and something should be done. If we look at oncology more specifically, which is the sector where I work, the oncology workforce crisis is particularly acute, and this is mainly related to the fact that we see increasingly a number of patients with cancer. So incidence is growing due to the elderly population, of course, aging population, but also due to the fact that increasingly we have survivors. So, which is very good, of course. We see that patients survive cancer, but then they need to be monitored for a very long period of time. And this creates additional pressure, of course, on the staff. So the demand is growing faster than, let's say, the availability, the increase of workforce to deliver the services. In terms of which sort of shortages we face in oncology is mainly oncology nurses, pathologists, radiation therapists, nuclear medicine specialists, and medical oncologists. These are the main, let's say, professions where we see a shortage of staff in oncology. I would say the consequences of this situation are clearly very, very important, potentially very, I would say, very, very serious if the situation is not improved. First, what we could see is a problem in terms of reduced access for patients, because if we have less professionals delivering care, then what we could see, of course, would be longer waiting times for these patients. And we know, for example, in the case of cancer, how important it is to have cancer being detected very, very early and being treated as soon as possible to ensure that we can improve as much as possible patient outcomes and ensure survivorship of these patients. Another important consequence of this situation is the mental health of health professionals. We see increasingly health professionals suffering from burnout and stress, lack of motivation. So clearly this is another very serious consequence. Third, a risk of increasing inequalities. We already have very wide inequalities in access to health and patient outcomes and survivorship. So there is a risk that these inequalities will even increase if the situation is going to remain as it is now or is going to become even worse going forward, because probably the more vulnerable patients will be the one then suffering most and not receiving the care that they need. And also, of course, geographical implications. Some regions probably would cope better than other regions. And finally, innovation bottlenecks. We see that in the case of oncology, especially, science is evolving very, very quickly. And we need to have the workforce to really adapt to this evolution, very fast evolution of science. And in case the workforce is so stretched that they cannot receive the appropriate education and training to learn how to take advantage of these new technologies will not reach patients ultimately. So we can already see the situation in relation, for example, to radioligand therapy, where a shortage of nuclear medicine specialists will lead to reduce access to this very innovative therapy. Another example, more, let's say, closer to your sector is the shortage of pathologists, which has an impact also in relation to access to genomic testing, because of course pathologists, they have an important role in relation to the selection of tests, the preparation of tissue sampling, and the interpretation of molecular results. So ultimately, all this would result in, let's say, problems of access, problems of lack of access to innovation, and also, I would say, much more difficult working conditions for the health workforce.
Thank you, Elisabetta. What a challenge we face now. So my question next to Xavier is, what are the implications of the current pathology workforce issues in cancer diagnosis?
Thank you very much, Marta, for inviting me to this session. I think I have been attending some of the previous lectures. They have been wonderful, very informative. Yeah, and the issue of pathology workforce shortage is very important. And I think it's not important only for pathology, as it has been mentioned before. It's important for patient care. We are very important. We are, let's say, crucial. More than 80% of the decisions taken in a patient with cancer in a multidisciplinary tumor ward are based on our report. So this is very important. Our specialty is very attractive, very innovative. We have seen that this morning. But we have this problem. And, you know, in the European Society of Pathology, we have the advisory board in which we have representatives of all national societies in Europe, and this is an issue. So this is very, very important. Which is the cause? How we can handle this? I mean, it's very, very difficult, and it has been mentioned. Of course, it's quite dependent on the attractiveness of pathology to medical students, I think. Of course, we cannot, we are not controlling the number of medical students in our countries. So this is something that it's a limitation. And we are competing with the other specialties. So this is something that it's difficult, because some of the other specialties are really attractive. They have the support even of movies and, in the media. So what can we do? We have to make strategies, this is my humble opinion, for medical students. We have to make clear what are the strengths of our specialty to medical students. And this is a problem, because I'm not absolutely certain about the situation in the UK, but in many countries of Europe, pathology is taught in medical school in a way that is a little bit diluted with other specialties. So, the issue is heard. And of course, the pathology is explaining, is touching pathology, at the same time of the clinician. So the problem is that sometimes in some countries, the figure, the role of the pathologist is not clear to the medical students. If you don't have that clear role, it is very difficult for you to take the decision to become a pathologist. And that is something that we have to improve. And this is not a task, of course, it is a task of the societies. And from the European Society of Pathology, we will take the challenge. But this is a task of all pathologists and also those that are associated with universities. They are tools to overcome that limitation. So, of course, we have to teach pathology in that integrated way. I think it's good. But there are seminars, there are many strategies in which we can show this forgive me for saying that, this Sherlock Holmes work that we are doing every day, and which is crucial. So I think this is the way to go. And different countries in Europe have performed several studies. In Spain, we are doing something. But I think this is probably the way to go. Of course, this is very important for us in the European Society of Pathology. We are thinking all the time on how to increase the visibility, because this is a problem of visibility. I mean, if we don't have visibility in the society, we will not have visibility in medical students. So this is very important. And this is also closing the gap between pathologists and patients. In many countries, the patients are really not aware of the important role that we have. So this is something important. But the European Society of Pathology is concerned about that. We recently, with the chair of the Education Committee, with Katerina Loy, we have launched what says Everyday Pathology, which is just a picture of what different pathologists are doing in daily practice, and we are showing that in social media. Let's see the impact that we have. Now in September, we will be participating in a multidisciplinary course for medical students with different societies. But I think this is something that we have to do together, and everybody, because here many pathologists are attending this session. Everybody is responsible for that. Everybody can, do something and increasing that visibility. Sorry for being so enthusiastic, but I think this is something that we have to do collectively.
I cannot agree more with you absolutely. So thank you, Xavier. I come back to Elisabetta again. So we have a picture of what is going on. My question is, what is the pathway to success to revert the present situation and improve the patient care?
Yes, this is a very important question, because we know there is a problem, but we have to find solutions, of course, to address this problem. I think Xavier has already explained very well the importance of making pathology, in the case of pathology, of course, more attractive to medical students. Absolutely, this is already one of, let's say, the measures to go in terms of trying to address the current shortage. I would say that probably the same would also be valid for nurses. We see that the students are not particularly willing to go into nursing. So how can we make also this profession more attractive for them? And associated to that, I would say better working conditions, because very often there is a problem also of the workplace not being sufficiently supportive for professionals. Related to this, making the workplace more supportive for professionals, I think that we should look more broadly speaking at the issue of retention. Because there are those who do not enter the profession, but there are also those who are in the profession, but they decide to leave the profession. We have seen a big crisis emerging after COVID. The workload was so acute, was so important, and the mental pressure also on health professionals was so significant that we saw a number of doctors, nurses leaving the professions, moving to other sectors, pre-retired. So this of course is something that is also very important in terms of measure, the retention, how we can ensure that those who are currently in the workforce will remain in that health workforce for as long as possible. Some solutions could also be found in relation to digital technologies. There is a lot of focus currently on the potential of artificial intelligence. Of course, there are opportunities, but I think it's early days somewhat to see how much these digital solutions could relieve, let's say, some of the workload instead of creating additional workload. So it's really an issue of seeing how we can maximize this potential offered by, I would say, digital technologies and artificial intelligence, which in some cases, I mean, if you take radiology, for example, I think that all this imaging, pulling all these images of patients could help also in terms of the diagnosis. So ultimately, you need, of course, a radiologist to read an image, but at the same time, they can benefit probably from some support being given to them by the, let's say, the use of artificial intelligence. But it's a little bit too early, I would say, to see which impact this would have. We conducted a big survey at the European Cancer Organization. We surveyed more than 700 cancer professionals to try to get a better idea of the challenges they are currently confronted to. And the results are quite interesting in understanding the, let's say, the problems that they currently face and to see how they could be addressed. So, for example, 90% of those who responded to the survey, they indicated that they experience high level of burnout. And this survey was conducted in the oncology sector only, but it was across different types of professionals in the sector. 21%, so more than half, said that they feel that their supervisors do not care about their well-being. 52% said that they have the impression that the workload was endless. So really the amount of work that they had. 55% said that administrative procedures are a main problem for them on a daily basis. And 77%, which is really a very high percentage, reported that they very often have to work overtime, and in some cases even without being paid for the extra hours of work that they do. So I would say it's really, the solution is really looking in the broad sense at every possible measure, initiative which could be taken to increase the number of professionals, to retain them, and to ensure that the work environment is sufficiently supportive for them.
Yeah, thank you. It's quite challenging, and I hope we see light at the end. So, with all the AI and digital pathology that Elisabetta was indicating, so what do you see, Xavier, is the role of the pathologists in the modern day, they say in the 21st century?
Yeah, this is, I mean, I'm really enthusiastic about pathology, how pathology is evolving, how interesting that is. And I think that over the last decades, we have seen how this role is changing. I think there is room of improvement, but you know, the old pathologist closed in the room, looking at the microscope, at the basement of the hospital. This is not longer the ideal situation. You know, we are now actively involved in multidisciplinary tumor ward and using very interesting techniques. Elisabetta, of course, alluded to molecular pathology. We are now very important, not only, you know, I mean, the control of the pre-analytics, this is very important. And sometimes out of the main focus is usually in the test, but the pre-analytics are very important. And we are responsible for this, the custody of the samples, but also the molecular test, how we are addressing, we are deciding the treatment that the oncologist is taking. So this is fantastic. And in the morning, there were a lot of discussions regarding, of course, digital pathology, which in my view, this is the way to go, and artificial intelligence. And I think some of the issues were also previously mentioned. So I see that this is the future. I don't know when, because some of the difficulties and challenges were also mentioned. I don't know when these algorithms will be there. I'm sure they will not be replacing pathologists. They will be just tools for us. Of course, they are expensive. That was mentioned, and that they should be available. But this is fantastic, and I think this is a fantastic future. But maybe we have, the pathologists also have to be a little bit proactive. And sometimes, when I'm talking to my residents, I say, maybe we have to go also to ECP, of course, the European Congress of Pathology, to USCAP, but maybe also go to ASCO and go to ESMO. There is a lot of pathology there. And sometimes we are receiving that information from the oncologist. Yeah. So I think we have to be a little bit proactive on that.
Yeah.
And also, and you, Marta, know that this is an area in which I have many interest in clinical trials. Yeah. So now many clinical trials in cancer are designed to have finally a biomarker. And the biomarker is interpreted by us. But we are not regularly involved in the design of the clinical trials, who ultimately end in a biomarker that we are supposed to interpret. So it's very important to be proactive, to be engaged, to be part of all these strategies, because the future is there. Of course, we need to have time for research. This is difficult when we are experiencing this shortage of workforce, but this is very important. We are crucial for the research in cancer, and the healthcare managers should understand that expanding in pathology is not only expanding, it's an investment. And I think these are all messages that we have to convey. I understand that this is difficult to convey to pathologists, which are every day working hard to get the diagnosis, but we have to be a little bit broad-minded to try to convince the authorities that it's very important to invest on us.
Thank you, Xavier. You are very enthusiastic. I love that, and I think we are in the same pathway.
I know.
In the Royal College, yes, this is what we are trying to do, and also in on top of ESP, ECP. And USCAP, I say, come to the PATSOX meetings in the UK.
Of course, sorry. Of course.
Okay, so it is now I will move to next two speakers that will again play together. And it is my pleasure to introduce Dr. Jan van der Thüsen. I don't know if I pronounce well. Jan is a deputy head of the department, an associate professor, Department of Pathology and Clinical Bioinformatics, Erasmus, Rotterdam, the Netherlands, and also he is the president of the British, Dutch, Irish division and Belgian division of the IIP. Thank you. And also with us, it is Professor Priyani Amarathunga, who is a good friend from Sri Lanka. Priyani is the professor in pathology, consultant histopathologist, Faculty of Medicine, University of Colombo, and also the president of the College of Pathologists in Sri Lanka. So, thank you for attending. And my questions will be first to Priyani. To ask, what is the current situation of the pathology workforce in Sri Lanka? And I put this question because I think that the workforce issues are all over the world. We know it's not just the UK, it's not just Europe, it's global. And but we think that sometimes the experiences from Western countries are different than from Sri Lanka or Asia. So we wanted to find out about the current situation in Sri Lanka and East Asia.
Hope you all can hear me.
Yes. Thank you.
Thank you, Marta, for the kind introduction, and also thank you for the organizing committee of the International Pathology Day to giving the Sri Lanka the opportunity to raise our voice on a shortage of pathology workforce, which has devastatedly affected our country due to some of the reasons different to the developed nations sometimes. The crisis of pathology workforce in low and middle income countries like in Sri Lanka, where we have 23 million people, has severely threatened the health quality as well as equity. If we talk about the number of pathologists in Sri Lanka, we have 23 million population altogether. The entire public health system relies on about 53 anatomical pathologists, 48 hematologists, and even fewer chemical pathologists in government hospitals. They are supported by a few more histopathologists and other specialties in the state university laboratories, contributing to the diagnostic service. And also, furthermore, it has been worsened by the maldistribution of pathologists across the country. Some of the provinces like Western Province and the Northern Province, we have one histopathologist for about 200,000 people, whereas if you travel further for few hours for North Central Province or Uva Province, we have one pathologist serving 500,000 people, that is 500,000 people. So this has impacted timely diagnosis as well as quality of reports, as a single pathologist of many centers must report all categories of specimens, and there is no room for subspecialization. The situation of universities is also equally critical. Across the country, we have 12 state universities which produce over 2,000 medical graduates annually. We have mere 15 professors in total across all pathology specialties in the universities. Some of the universities run with one single senior lecturer supported by few junior lecturers. Despite these limitations, the country maintains high standards of our graduates, enabling them to find jobs easily everywhere in the world. The local postgraduate training is in par with developed countries, offering wide exposure, as well as all kinds of specimens and clinical settings are exposed. So this high standard allows our trainees to easily acquire overseas qualifications like CPAT fellowships, and either during or even before their 1 year compulsory overseas training. So in Sri Lanka, in postgraduate training, we have 1 year compulsory overseas training period, which has brought many benefits to the country as well as to individual pathologists. The young pathologists equipped with new knowledge and the experience in working in state-of-art laboratories, returning back to Sri Lanka, they are implementing those in the remote hospitals and are benefited by people in the country. And also, they establish connections with those people for future collaborations, obtaining expert opinions, and also for peer review. So in that case, that overseas training has been greatly benefited, and we think that it should be continued. However, this mandatory overseas training has created an easy path for brain drain in the country. So country invests in producing highly qualified specialists, as the training program is fully funded by the government from school to higher education, even this postgraduate training, overseas training included. But we are unable to keep them after training. So if I just talk about the statistics during last 5 years, we have 69 MD histopathology trainees qualified for last 5 years from 2020 to 24. But during these 5 years, the number returned to Sri Lanka after training is only 22. That is just 1/3. And within that 22 also, the number became board certified locally and stayed back in Sri Lanka for service is only 12. So in average, we are training more than 5 times the specialist we retain in the country. Not only the pathologists, the staff in paramedical categories are also severely affected. Our community-based cervical cytology screening relies on nearly 50 to 60 cytoscreeners nationwide. The shortage of technical staff is due to both migration as well as government recruitment restrictions following the recent financial crisis. So we are looking for some solutions for this. This is the current situation in Sri Lanka.
Thank you.
So with this shortage, the diagnostic delays across the country, as well as the already devastated, the specialists who are remaining in the country are desperate and they are burnt out with their heavy work, and also further chances of leaving the country. And this situation also has hindered potential subspecialization in the country because we have only very limited number of pathologists covering all the specialties. So those are the challenges that we are facing at this moment.
Yeah, thank you, Priyani. Thank you very much for a very thorough presentation of your situation in Sri Lanka. And okay, so I think that the next question maybe will address some solutions. So my next question is to Jan, to ask him, what do you see will be the role of AI and digital pathology, not only in the developed world, but also as a tool to collaborate with low to middle-income countries?
Many thanks, Marta, and many thanks for the invitation to talk to you all today. So I had the great luck of having been invited by Priyani a couple of weeks ago to the 50th anniversary meeting of the Sri Lankan College of Pathology, and I think I was struck, not unexpectedly, I have to hasten to add, but by the level of pathology which was on display there. I think the training which they offer and that Priyani has been talking about is first class, and I think the problem is mainly retention, as was already mentioned, and I think that's something that we need to find a solution for. So specifically referring to digital pathology and AI, and we've heard a lot about that already today, and the promises that it can offer us, and which have to some extent already been fulfilled. Others are perhaps a little bit more aspirational. I think those promises are shared by both the higher income and the lower middle income countries, but they may be even more important for the LMICs. So we're now a fully digital lab in Rotterdam. We have been for a couple of years, and we installed the first scanner about 20 years ago, and we didn't install that scanner for the workflow. It was installed specifically for educational purposes. So I think this is one of the very important roles that we can afford to digital pathology. And that's not only to our own undergraduates, and I agree with Xavier that it's important to be attractive as a community, as a subspecialty to these potential undergraduates who might go into training. And I think we have to represent ourselves as a modern and dynamic specialty. And I think presenting what is possible in terms of technology, including digital pathology and AI, I think early on in the educational process is very, very important. Then you can also, of course, use digital pathology to educate your own trainees, but the BDIP is particularly interested, of course, in postgraduate education as well as trainee education, also in an international context. So we run several international schools of pathology, of which one is in Sri Lanka, but also one in East Africa. And I think digital pathology is very important in actually providing pre-meeting access to these images, so that the participants can also experience the various cases that we will be presenting, and perhaps also after the meeting, and come to grips with the details of the individual cases. So I think that's very important. We also are involved in organizing webinars, and I know the ESP is as well. I've done a few webinars for the ESP, and again, digital pathology is crucial in offering that type of capability, and also again sharing those cases and perhaps in larger databases as well. I know the ESP is also setting up a larger database from, for instance, the Kansas cases that are being sent around the world. So I think that's crucial for postgraduate education. So when it comes to introduction of digital pathology in the lab, so I think first and foremost, everybody always thinks about workflow efficiency, and that's certainly true. So our technicians are not walking around with glass slides all day anymore. So they go into the scanner and we can look at them at our workplaces. I think that also makes the profession potentially more attractive in that it increases equality. So I have some colleagues who, for whatever reason, sometimes would like to work at home. It's much easier to actually report from home, and having that potential possibility available, perhaps even doing that in the evening hours, I think that makes the specialty more attractive. It is also a very good way of seeking low threshold consultation advice from colleagues. So I do that all the time nowadays in the department, just send a chat to a colleague via the image management system, and they can look in real time with me at the same case and give me an answer. They can do that across departments, of course, to other hospitals, across nations. So for instance, we run the Dutch thymoma panel from Erasmus, and that is an international panel. So you can submit a thymoma case, and an international panel of subspecialty experts will look at these cases and report back. So I think this offers also opportunities, certainly to LMICs, to participate in these sort of possibilities, and actually also for their own subspecialists to take part in these larger networks of pathologists. And then lastly, of course, the AI tools. I think it's very difficult to write a positive business case for digital pathology without including AI. Yeah, so that is something that I think holds more promise than it is delivering at the moment. But I think time will come that we introduce that into everyday practice. And I think this could be a real democratizer. So we've heard a few talks today about using H&E images to train these AI models. That's as cheap as you can get, right? When it comes to the laboratory costs and the consumable costs. And if that can help you to improve your workflow towards ancillary techniques, perhaps exclude cases which will not benefit from these ancillary techniques, or select cases that will, such as immunohistochemistry or molecular diagnostics, I think that could leapfrog some of the very expensive developments that we're seeing in molecular diagnostics. So I think we're not anywhere near that yet, but that may happen in 5 or 10 years' time. So it could actually lead to a closing of the divide between the developing and the lower middle income countries. And finally, I think we need to, just mentioning this, I think we need to be aware, and that's also why it wasn't a coincidence that I added my name to the earlier question today, to be aware that funding is an issue. And it's not only an issue for the LMICs, it's also an issue for the richer countries. So we have a very well-funded healthcare system. Still, we don't have reimbursement. And I think the responsibility for this lies not only with us as the pathology community, it certainly does as well, but I think it also lies with industry to keep this type of AI accessible to all.
Absolutely, absolutely. So thank you very much for all that comments and insights. So my next question would be for both of you, for Priyani and Jan, because AI, digital pathology, all fantastic, technology, but the reality is that we need something now. We need a workforce that is ready to cope with the gaps in the workforce numbers now. So one option would be the pathology assistants. And my question would be for both of you, what will the advantages in expanding the numbers and knowledge of pathology assistants to balance the workforce issues, both in Europe, in the Western, and in low middle income countries? I don't know who wants to go first.
Jan, would you?
Yeah, I'll go first if you like, Priyani. Yeah, sure. So we've been working with pathologist assistants for a while now, and to great effect, I have to say. And we couldn't do without them anymore, and that is precisely because of the workforce issues that we've all been facing. So I think about 80% of cut-up nowadays at Erasmus is done by pathologist assistants. You always have to be careful that you don't de-skill your pathologists and that you adequately train your pathologists in training. I think there needs to be still some volume that we do ourselves, and they do it very well. I think what is important is that we provide training and that we harmonize the training and standardize the training so that pathologist assistants from one center to the next have the same skill set, and ideally also across borders, potentially within Europe, but also globally. So I think that needs another set of sort of training programs. For instance, this coming Saturday, I'm talking to our own pathologist assistants, a yearly meeting, and I think to have that connection between the pathologists and the pathologist assistants is crucial. We need to continue working as a team and to have that exchange of ideas and experiences. So I think it is very important, and it is certainly a way of going about trying to address the workforce problem. I think it also, we've been talking mainly about the pathologists today, but I think it is also something that is very useful and very important in affecting retention of the biomedical scientist staff, because I think this offers additional sort of depth to their jobs and their career paths, which is very welcome. Not to everybody, not everybody wants to do this, but for some of our very skilled staff, this is certainly something that keeps them with us and also keeps them fulfilled in their current job.
The situation in this Sri Lanka is the pathology assistant as a scientist is not existent. Most of the training centers, the cut-ups are done by postgraduate trainees in pathology. And also in the other hospitals where there are no postgraduate trainees, there are medical officers in the pathology laboratories. They assist in doing the cut-ups. So the situation in our country is having a scientist as a pathology assistant may be helpful, but we need a lot of regulations, the job descriptions, and then standardization of practices. All those things should be systemized, come into order before assigning scientists as pathology assistants, because there can be a lot of systematic errors happening. And for the safety of the patient as well as for the quality of the report, still in Sri Lanka, each and every report is signed out by a consultant histopathologist. That is the situation in the country.
It's interesting because just to add, in the pediatric pathology world that we have in the UK, a 40% gap in positions not fulfilled. We are now will be introducing the diploma in pathology reporting run by the college and under the governance of the college, and it's going to be a 2 years training for BMSs trained into grossing and reporting placenta. So yes, I agree with Jan, is the way forward, and also the training issue. And it is my pleasure now to introduce Dr. Russell Dacombe, who is a Senior Research Associate and Lecturer at Liverpool School of Tropical Medicine. Russell is an experienced international researcher and consultant who specializes in diagnostic system and policy and regulation development and implementation in developing countries, and also diagnostic aspects of antimicrobial resistance, tuberculosis, malaria, etc. So thank you, Russell, for joining and for accepting to join this roundtable. And I would like to fire the first question. What areas of workforce capacity shortages impact upon the establishment and maintenance of laboratory quality management systems?
Thanks so much, and thanks so much for the opportunity to sit and speak on this roundtable. As you alluded to, almost all my experience in Sub-Saharan Africa and Southeast Asia, so I'll talk from that perspective. I don't think a lot of high-income countries necessarily have some of the challenges that I'm going to talk about, but I'd like to put the low and middle-income cases forward. So from working primarily in these areas, there's a number of different associated professions that impact directly on the capacity of laboratories to actually develop and maintain quality management systems. So the one that I've noticed probably the biggest impact has been on biomedical engineers. So the ability to have a cohort of people within a country that are able to fix and maintain equipment to a standard that's acceptable by international standards organizations. So I've seen this recognized as far back as 2003 when I worked in Malawi. This shortage was very much recognized. People were trained and then the cadre was disappeared as this wasn't supported. So I've slowly seen this improve in the countries that I work in. I was recently in Uganda and I saw a fantastic program with fantastically skilled biomedical engineers, but then you would go to another country and people would face very severe problems in maintaining their equipment. So as with everything I'm going to say, highly context dependent. So these are generalizations. Also around, I alluded to actually the quality management systems themselves. So we'll all be are very aware of ISO and ISO 15189 and 17025 and everything. So actually getting assessor capacity for bodies to assess laboratories was very much an issue, particularly in sub-Saharan Africa about 10 years ago, when if you wanted to be assessed, you're really looking at South Africa or Kenya. This capacity has increased, but now we have a shift that lots of assessors can now do general lab quality, but now countries look to establish their own external quality assurance system. The assessors now for that are now shortage. So I recently worked in Pakistan where we set up an EQA system. We've been waiting 2.5, 3 years for it to actually be accredited because the capacity is not there. So as lab services expand and national remits expand, it's worth expanding those assessors as well. Mentorship for those quality management systems, again, very little of it around 20 years ago. Slowly that capacity has grown, but a lot of research indicates that if you're going to put a lab management quality management system in place, you need mentorship to both accelerate the process and make sure that you don't go through multiple rounds of assessment. So again, WHO has a SLIP tool, but without the mentorship to come alongside that, it's very difficult for labs to actually manage that, particularly with biomedical scientists, workforce shortages that there are across the globe. Also, when you're talking about labs, you're talking about the devices that are working in them. A shortage of medical device regulators is a big problem across the globe. So a lot of money has been put into pharmacological regulation, and so a lot of your pharmacological regulators are also your medical device regulators, and sometimes the capacity is very much skewed towards the pharmacy rather than medical device. So again, you're getting barriers to devices coming into country, or any device can come into country, and then it's beholden on the lab to do many tests and requirements to make sure that they're fine. We've talked a lot about education and educational throughput. That remains, various, how medical students are trained, opportunities for biomedical scientists to go for postgraduate training. The capacity of national institutions to do that is, again, contextual, but can be very limited and can be a barrier to retention and increased capacity. And the last thing I'm going to mention for now, for time, is contractors. So actually the building and refurbishing of labs in LMICs can be quite a big issue in terms of contractor specialization and capacity to actually build and refurbish those labs to a reasonable standard. So I've done a lot of work in this area, and large contracting companies are very often not interested in lab projects because they're too small, unless you're building a whole hospital. So then you get smaller contractors come in who may not necessarily have the capacities to build those facilities. I cannot tell you the nightmare I've had trying to get epoxy benches done in different countries to a high standard. So all these things that we might take for granted in high income settings can be very, very problematic to actually undertake, particularly with budgetary limitations as well. So that's some of my thoughts.
Thank you. It's amazing because you are actually, conveying to, at least to me, all this background information that, you have it for granted and you actually don't consider, but this is an amazing issue. So my second question for you would be, how do you think that the recent drop in international aid spending will impact the development and the implementation of diagnostics in low-middle income countries?
Thanks very much. Not a controversial or sensitive topic at all. So that's good. We'll get stuck right into that. So I think the
names.
No names. Nobody will be named. So I think the immediate effect we're likely to see is actually on equipment investments. So I can see, if investment is going down in equipment, then manufacturers will scale down their support for equipment, and this will then impact on the quality and volume of data that's available. As you mentioned, I work a lot in AMR. So a lot of AMR international surveillance is around bloodstream infections, and that means there's been a lot of investment in automated blood culture machines. And when countries have purchased or had these machines purchased for them, we've seen when consumables are made available by international donors, our blood culture testing goes up. When that's dropped off and countries have to work on their own domestic markets with the fluctuating exchange rates, blood culture volumes go down. So this sustainability of these type of technologies when funding is cut is going to be an issue about whether countries can actually take on these very high level, expensive machines. As I say, particularly when manufacturer support may not be as available or as reasonably cheap as it is in Western countries where there's a higher volume of these machines. Again, because this will then potentially throw the cost of a lot of these tests even further back on patients, you're then looking about inequalities of service with patients as well. And not only these inequalities directly impact on the most vulnerable in our society, it's often that these areas are also have higher disease prevalence, high AMR prevalence. So again, not being able to offer these diagnostic services to people in these areas may also compromise our ability to detect outbreaks early. They also might compromise our ability or further compromise surveillance systems as well, because you'll be in surveillance a much more biased set of the community. So this lack of investment could result in countries or pivoting to cheaper diagnostics, which is fine, but these diagnostics could be less effective. They could be more time consuming for labs. One of my least favorite tests to see is the Vidal test for Salmonella typhi, which is a pretty inaccurate test. You still see that around. I can see countries pivoting back to tests like that, merely because they're cheap and merely they can offer that type of test in that lab. However, on the plus side, a removal of funding will also mean that countries may well pivot back to more autonomy and may make their own decisions a bit better. We published a paper with a colleague of mine, Ivor Langley, that looked at TB diagnostics and the fact that I think a lot of people might know the Gene Expert machine that was, very bigly pushed about 10 years ago. That would have cost the entire budget of the Tanzanian TB service, but something like fluorescence microscopy might have been a better choice had there not been a donor. I'm watching the time here, so I'm going to just say here, I think the last thing that I want to talk about, there's much more I could talk about on this subject, is the cuts on international organizations such as WHO. So WHO pre-qualification department does a lot of work in terms of device regulation, and harking back to your previous question, device regulators are have limited capacity. And also if there's a regulation environment in a continent such as Africa where there's lots of different criteria, then manufacturers are less likely to get involved in a particular country. So therefore, it makes entry into the market for new diagnostics more complicated and less attractive for manufacturers. So there may well be a drop of investment in diagnostics for diseases of low middle income countries. And I'm going to stop there, but I can take further questions on it and we'll be happy to talk for another half hour on this if necessary. But thank you very much for the opportunity to speak.
Thank you. It's very, very useful, very, very sad. At the same time, it's a lot of work to do here. So thank you for keeping on the time, all of you. So first question. This is an important talk, how to support colleagues changing careers pathway from other careers, medical careers to pathology. So I think that this may be for Jan or Xavier.
Yeah, Xavier can take that one. Yeah.
Yeah, take it. I think we have to, I think that Jan and I have been closely aligned. We have to, our specialty is very attractive. So we have to make that clear and to emphasize the interesting things in which we are involved. So that will be very important. I don't know, Jan, what do you want to add?
Yeah, I fully agree, and I think you mentioned it earlier. The way that biomarker testing now rests squarely with pathologists sometimes, and we form such an integral part of the care pathway. I think that's something that sometimes isn't clear to our perhaps the other colleagues or also our medical students, to which extent we determine the outcome for patients, and we determine also the therapeutic choices which are made, and that we're such an integral part of clinical medicine. Unfortunately, that also means that I sometimes see my clinical colleagues more than I see my pathology colleagues at the lab. But I think that is also the way it is. And I do go, as you suggested, also to ESMO and so on. And I think that is attractive to people who come from perhaps clinical professions or who are starting out as students and are looking for a specialty.
Thank you. I think that Xavier, we talk on this, but this is open to all of you. Maybe Elisabetta not, but it's not.
But Elisabetta is very important because
about how to make pathology more attractive. All of you, please. How to make pathology more attractive to students. This is something that you mentioned, Xavier, but I think that we all have an insight onto this. So I don't know if you want to start.
Well, everybody has tricks on that, and at least in Spain, I see that there are some universities that are more successful in getting pathologists than others. So that means that there is this, let's say, inter-observer performance, inter-pathology performance. So I'm quite successful. I'm not the most successful, but I am quite successful. What I'm trying is to organize seminars in which, very difficult cases, which are real cases, but that, our opinion, our study changed really the life of the patient, and they realize I'm calling that the Sherlock Holmes role of pathology. And every day we have examples of that. So I think this is something that we have to play. Every year that I start medical school, I explain that. So I'm saying this year I'm going to teach you pathology, but also I'm going to show you what a pathology is. And this is my goal, and if we do that, and there are people that are really pathologists that are very good on that. So yeah.
The Royal College has done some podcasts a couple of years ago, and I was very touched by a trainee who said, I'm doing pediatric pathology because I listened to your podcast when I was a medical student, so this was fantastic to me. Also, I think that the observerships, that having the medical students to come and do placements, helping them do an audit, a service evaluation, a presentation, an abstract. The Royal College has a lot of, for medical students, of competitions, essays, etc. You that are in the British division, Jan, or Elisabetta, Ineco, Xavier, Priyani, you are all in positions of relevance. Invite students to attend the conferences for free. I think that would be terribly attractive. But yes, I don't know if anybody wants to add something before we move to the next question.
Absolutely, Margaret. So yes, I mean, from the BDIP, for instance, we offer bursaries also to undergraduates to attend these conferences, and I fully agree with you that having these possibilities of attachments, I think they're very, very important, particularly in the clinical phase of the training, where it's logical to do a clinical attachment with one of the clinical departments, but not necessarily with pathology. And one more thing perhaps is also the visibility and the way that we're portrayed in the undergraduate curriculum. So I think that's something that we continuously have to fight for, to have that visibility and not just be there to explain histology, right? So I think that's something that is important, that students from the first day almost realize how central pathology is to what we do in medicine.
And if I can add something, Marta, also to fight not to be in the basement of the hospitals. So our place is closer to the operating room, is closer to the place where the patients are. And being in the base, I understand that this is difficult, but being at the basement is not good for us, because this is closely related to a bad visibility of our specialties.
Absolutely. Very helpful. Something to say, I also think that we need, as pathologists, to, from the big societies, colleges, speak to the universities, medical schools, to make this space for pathology in the medical curriculum or in the curriculum of doctors, because otherwise, as you say, it's invisible. And so another question is, how do we realistically raise funding allocation? I think this is very important, at least in the UK. Funding allocations towards training more pathologists. Is there any grassroots movement that we can support? I think this is, this is by the deaneries. This is, at least in the UK, is funded half by the trust, NHS, that there is no budget, there is no more money, and half by the deaneries. So I think that is an issue, at least here. I don't know if another part of Europe is an issue with the funding allocation for training numbers.
Yeah, it's quite heterogeneous across Europe, I would say.
Yeah, we are doing from the college. I can confirm that we are trying to influence this. Is, as I say, influence, because it's not our decision. But thank you very much. It's been an honor to be part, have you in this roundtable. Thank you.
Thank you very much.